At this time, I'd like to welcome everyone to our webinar today on metabolic syndrome and the CKD patient. Today's webinar is sponsored by Pentec Health with our esteemed speaker, Carl E. Dukes. A nephrologist will be doing the presentation. My name is Lynn Leonard and I will be your moderator. But before we get started, I would just like to go over a few details about the webinar. All attendees have been muted for your convenience. If you have a question during the presentation, we ask you to use the Q&A box that is located on either the toolbar at the top or the bottom. It'll be labeled Q&A. You can open that up and type in your question when you have it during the presentation. And there will be a Q&A session at the end of the presentation where the speaker will answer these questions from the audience. The webinar will be recorded, and the recording will be available at proplete.com, as well as other recordings from past webinars. So without further ado, I'd like to introduce our esteemed speaker, Dr. Carl Dukes. Dr. Carl Dukes is a native from Atlanta, Georgia. He received his undergraduate degree in mathematics from Cornell University and his medical doctorate degree from the University of Rochester. He completed his internship and residency at the University of Alabama in Birmingham. Upon completing his fellowship in nephrology at the University of Texas Health Science at Houston, and after serving clinical and consulting roles at both the Health Center of Houston and MD Anderson Hospital in Houston, Dr. Dukes entered private practice. He has been in private practice since 1983. In Houston, as well as having a solo nephrology practice operating in an indigent part of San Antonio, Texas. And he is the medical director of the Houston Street Dialysis Facility. His interests are in the management of hypertension and diabetes and how it impacts kidney function and disease progression. So without further ado, we'd like to present Dr. Dukes and our webinar on metabolic syndrome and the CKD patient.
Well, thank you and welcome everyone. This is a very interesting topic because we talk about the metabolic syndrome, and we have a real quandary here in our world. About half of the people are dying from starvation, and the other half are dying because they eat the wrong things or overeat. And so we want to think about the metabolic syndrome, think about chronic kidney disease, but not so much as one specific entity. But this is all tied in together because basically metabolic syndrome increases cardiovascular disease, as we well know. But you have to think about cardiovascular disease as thinking about different tissue beds. And we basically have three types. We have the large tissue beds, which is really basically the carotids, your femoral arteries, and that sort of thing. The medium-sized vessels are your coronaries, and the microvessels are your eyes and your kidneys. So obviously I deal with more microvascular disease, but if you were to take a cross-section of that vessel, it all looks the same. So basically we've got two sides of modern civilization. We don't have to go from day to day. And then the developed world is good. We live a comfortable lifestyle. We have 24/7 access to great tasting food. We can get it anytime we want. In fact, they can deliver to you so you're not even shamed into overeating. We have 24/7 access to entertainment, and modern medicine is helping us live a lot longer. But, next slide. Too much food, too little movement, too little sleep isn't good for us, okay? And many health problems are caused by unhealthy lifestyle. Actually, you can see about 70%, as you can see this slide, and I'm not going to read each little line of the slide, but modern medicine has helped us compensate for our health problems caused by unhealthy lifestyle. We've got medications, we've got all kinds of interventions that actually can repair clogged arteries and control other types of problems related to these lifestyle changes through pills. As a result, the motivation to change how we live is very low and non-existent in many. Now, we think about modern civilization, and actually, if you look back to the ancient Egyptians, they had similar problems. They had DJD, they had carious teeth, they had gout, and they also had atherosclerosis. This may be attributed to the fact that we became agrarian. Okay, and later we may even discuss the fact that we're probably a glucose intolerant entity. Next slide. Is there a biological link between these problems? Many people have two or more problems. And the thing is, we've known as healthcare professionals that these issues increase your risk for medical problems. And we started to use this term metabolic syndrome because we really didn't have a link to really put it together for a long time. And this was actually Gerald Reaven in 1988 called this thing the metabolic syndrome. In fact, I think he called it the syndrome X. And basically, we later find out that this is really approximately related to insulin resistance, okay? So we know that the metabolic syndrome, people are twice as likely to develop heart disease and 5 times as likely to develop type 2 diabetes. Next slide. And so it's not something to be smug about. You can see that it has a major impact on mortality. And some colleagues evaluated differences in mortality between subjects with and without the metabolic syndrome. As you can see here, all-cause mortality was significantly higher in subjects with the metabolic syndrome, 18% versus 5%. And cardiovascular mortality, 12 versus 2. So being a little portly in the midsection is not the best thing to do. And so, again, all-cause mortality is not just a heart problem. It may be a kidney problem. So tissue beds, remember, large vessels, medium-sized vessels, small vessels, they're all impacted by this. Next slide, please. When is the metabolic syndrome normal? Of course, everything that goes on in our body has been several mechanisms for survival. What happens is man kind of screws it up, if I may use that vernacular, and takes something that was perfectly adaptive and made it maladaptive. You can't leave things alone, so to speak, okay? So the metabolic process that now leads to the metabolic syndrome is actually needed to help us survive in times of famine, because you think about it, we were not getting meals on a daily basis. And so 2 of the key players involved in this was insulin and glucose, because glucose was our main energy source. And if you think about it, and all the people who are there oriented toward biochemistry, that term gluconeogenesis is very important, because glucose metabolism is the backbone of all of our energy production for our body for the most part. So insulin directs glucose to be used for energy, but it's basically a storage hormone. So if when we were hunters and gatherers and we got a good kill, so to speak, we would eat, and then if we needed, and then we ate in excess, we didn't have a refrigerator or a deep freezer. So basically, insulin was stored around our midsection for a rainy day. Okay, long-term excess food intake will develop this excess fat stored in the abdomen, because that's basically where this excess is more available. As one of the frustrating things for ladies, they tend to gain weight in the hips, and but that fat is not metabolically active. It's hard to get rid of, and women are frustrated by that. Men tend to get centripetal fat. They get a pot belly, a bay window, and that is the one that's metabolically active. Fortunately, you can gain it very quickly, you can lose it very quickly, which always causes angst among couples, because the guy usually can drop pounds a lot faster than the woman can. But the hips are not the ones that are going to kill you. So it's okay to look like a pear, even though you may not look as nice in your pants or whatever, but being an apple is what's going to kill you. So if a famine never happens, there's a buildup of excess fat, you get this central obesity. Next slide. In animals, geese flying south for the winter, bears in the month for hibernating, humans, we need it too. Basically, you think about puberty, pregnancy, aging, and most of us are kind of descendants of hunters and gatherers. So this was a protective evolutionary biological phenomenon that went awry because we have too much caloric intake. Most of us have or will have the metabolic syndrome, and you know what you look like when you came out of the shower. So if that was not a beach body ready body, you know you probably already have the metabolic syndrome. We just don't like to admit it, but deep down inside, most of us are, because most of us are heavier than we need to be. Okay, next slide. How do we define this? It's a combination of medical disorders that increase the risk of developing cardiovascular disease and diabetes. The metabolic syndrome has also been known as the dysmetabolic syndrome, syndrome X, insulin resistance syndrome. In Australia, it's called CHAOS, and it's just an acronym for coronary disease, hypertension, arteriosclerosis, obesity, and stroke. Next slide, please. So everybody's familiar with this. You need 3 or more of the following: abdominal obesity, male waist has got to be greater than 40 inches, female greater than 35, triglyceride levels greater than 150, which is probably a reflection of some issues with your glucose metabolism because triglycerides is basically a 3-carbon glycerol, which is coming from glucose. So triglyceride levels being up, you've got some problems with your glucose metabolism. Decreasing HDL cholesterol. I have to tell my patients, HDL, highly desirable lipid, that's the good cholesterol. That's the one that kind of vacuums some of the plaque out of your, that plaque and atheromata out of your arteries. So you want that, but unfortunately, it tends to drop. So males is less than 40, females less than 50. Blood pressure. You're not frankly hypertensive, and this makes, this is actually, when you look at the newest JNC, these parameters actually are hypertensive. But the point being is that you're getting a trend with elevated blood pressure. For people that aren't aware, usually when you're starting to get into this labile place with your hypertension or with your blood pressure, you, over the next 10 to 15 years, greater than half of these people will have established sustained hypertension. Increase in fasting glucose. We say diabetes if the fasting glucose is greater than 126, but we say impaired glucose tolerance if you're above 100. So you're in that. And most of these data and these guidelines were based upon the smart people, I guess, the National Cholesterol Education Program, or NCEP. They got all the great minds got together and came up with this. So you just need 3 of these. And so if you think about it, a little too big in the midsection, triglycerides up, low HDL, blood pressure's creeping up, increasing glucose. So this is going to be how we define the metabolic syndrome, having at least 3 of those. Next slide. Who is at risk? When we think about it, who is at risk? Chronic fatigue, carbohydrate cravers, all of these things. But the point being is that besides those with high blood pressure, diabetes, and cholesterol problems, all these other signs and complaints as listed here are putting you at increased risk for the metabolic syndrome. Not getting enough sleep causes several metabolic changes associated with the development of the metabolic syndrome. Obviously, people who don't sleep well, and you've been hearing this in the news medium, whatever, is that we gain weight. You increase insulin secretion. And see, the thing is, insulin is basically a storage hormone. So if you increase your insulin levels, you're going to have a tendency to gain weight. Not only in terms of fat, but also, we don't think about it from a nephrological standpoint, insulin increases the proximal tubular reabsorption of sodium. So you not only get a little fat, but you also get puffy and swollen, okay? Decreased growth hormone release, decreased testosterone, increased evening cortisol levels, which is, normally your cortisol levels should nadir in the evening. So you got yourself running full throttle all day. And so all of these things are going to cause problems. So we recommend people get about 7 to 8 hours of restful sleep. We all say we should eliminate our stress. We live in a stressful society, but one of the problems is that primates don't let go. There was a nice book by Robert Sapolsky out of Stanford. He's a psychologist, and he had a nice book, and some people may have read it or heard of it, it's called Why Zebras Don't Get Ulcers. Now, it sounds kind of cute and quippy, but basically the whole idea is that in the animal world, they quote unquote let go. Okay, so the zebra is being chased by the lion or whatever. So both of these animals are being stressed, but this stress is going to be over in about 30 seconds, a minute at most. So either the zebra gets away or he doesn't. He's dead. The lion doesn't get the zebra or he does. But one thing, they have a very short attention span, so they just move on to the next day. We harbor grudges. You come to work and you say, I cannot believe this guy ran the stop sign, da 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 da, and we just continue to chronically seethe. So unfortunately, primates and man, we're primates, but man continues to kind of harbor all that stress, and that's what tears us up. So we should probably be like our pets. They kind of live in the moment and they let it go. So carrying these grudges and vendettas is not healthy. You're only hurting yourself. Next slide. This is just a picture of somebody who has a metabolic syndrome, and everybody's seen this, the quote-unquote acanthosis, the dirty neck, the mothers are scrubbing the kid's neck, and you always think that there's something, but basically what you see are skin tags and darkness in the skin around the neck, but you can see that in other parts of the body where skin touches skin, such as under the arms, the axilla, under the breast, and around the waist. Unfortunately, around the waist because they've gotten this, it's a little pannus there. But this medical term is, if you don't know, it's called acanthosis nigricans, and it is a harbinger and a predictor of metabolic syndrome and subsequent diabetes. Next slide. This slide is a little busy, and I'm just going to kind of talk about it, and you can kind of absorb it, but there are multiple associated health problems, and these associated health problems are related to being overweight. And there are at least 7 hormones that get kind of disarrayed when you become heavy and overweight. And the problem is it affects your brain, lungs, metabolic, gallbladder, coronaries, osteoarthritis, gout, vascular problems. And what we think about is this. We used to think about fat cells as just this passive bag, just like a bag in it to store fat, but it turns out adipocytes, these fat cells, are actually metabolically active, and you've probably heard the fact that they release hormones. In fact, hormones also release inflammatory cytokines. One of them is interleukin-6, which causes all kinds of inflammatory processes, okay? And this is going to kind of be the segue to we talk about chronic kidney disease and atherosclerosis. Adenopectin, the levels are decreased and in metabolic syndrome, and this causes the problem is that what this does is that adenopectin normally will increase glucose uptake and decrease gluconeogenesis. So if the adenopectin levels are lower, it's just the other way. So now we're generating more sugars than we need. Okay, also, we have aromatase. Aromatase will make estrogen from androgen. So you see, you can never see an obese male looking quote unquote ripped because even though he's making testosterone, aromatase, which is coming from that fat cell, cleaves that 17th position carbon and makes it a 16 position carbon, which is what estrogen is, because testosterone is converted to estrogen. If you think about it, this is why you have problems with cancers of the breast and uterus or whatever, because if you're obese, these fat cells continue to make a lot more estrogen. Okay, so that's one of the biggest risk factors for uterine cancer and breast cancer is obesity, because those cells are now making more estrogen. So you don't need an ovary to make estrogen. Tumor necrosis factor causes systemic inflammation. We've got resistin. Resistin is released from these fat cells. It increases your bad cholesterol, your LDL cholesterol. It increases LDL production in the liver and degrades the LDL receptors in the liver. So you can see how we're going with this. So it's shown mystery why we can have atherosclerosis. You have your leptin levels drop, and that's inverse related to satiety. The more leptin you have, the more satiated you are. plasminogen activator inhibitor is increased and what is decreased, decreased, and it inhibits fibrinolysis. So if you get more of this, you're going to have vascular problems. That's why you have the problems with blood clots. Also, one of the problems is that you have a dampening of the muscle pump effect, let's say in the calves, because when you move, the gastrocnemius muscle kind of squeezes those veins. But if you got a layer of fat between there, that's dampened. So it's no mystery that you end up with chronic venous insufficiency, chronic fluid retention in your legs, and blood clots. You get gout because you got a purine metabolism issue. You got osteoarthritis. This is simply physics. It's just the fact that every time you gain some weight, you know, when you gain so many pounds, you basically double the stress on those joints. So I mean, you can't weigh 100 pounds more than you should and expect to have normal joints. Okay. The gynecological issues we already alluded to when you talk about, excuse me, excess estrogen. If you have excess estrogen, you're not going to ovulate. You got gallbladder disease because you got the screwy cholesterol and the cholesterol bile acid ratios get out of whack. Glucose problems. How do you get hypoglycemia? You get hypoglycemia because people are chronically insulin. They have excess insulin, so they get on this roller coaster. You have excess insulin, you have a tendency to drop your sugar. Then what do you want to do normally is that you're going to binge on some more glucose, which just sends it again. And so one of the findings you find out that these people who are having, quote unquote, I guess that's the cheeky term, reactive hypoglycemia or whatever, are people that are probably going to develop some diabetes down the line. Fatty liver, which we're going to talk about specifically. But that is just due to this tremendous fatty acid storm because you've got insulin resistance and not able to turn off the breakdown of fatty acid metabolism. Lung disease, well, you can get obstructive sleep apnea because you simply are changing the physics of your upper airway. You get a little fat in there, you're going to change the airway flows, okay? Also, now you got some chest wall issues because you've got a lot more weight to move around, okay? Mental fatigue, you can have strokes, depression, coronary disease, I think it speaks for itself. I've already dropped my HDL. I'm increasing my LDL. I've got some hypertension and so on. So you can see that it's not just a diabetes thing. It's the whole package. And a lot of this is related to either carcinogenesis or atherosclerosis. Next slide. So we talk about metabolic syndrome, and this is the hot topic, button topic now, because this is the most common cause of chronic liver disease now. It's no longer hepatitis. Well, we know hepatitis C is going to be a thing of history, and alcohol is not it. And we've got the other hepatitis controlled, and it's basically we get fat, and we get fat in our liver. So if some wonder if this is a liver manifestation of metabolic syndrome, but the strongest associations are with obesity, particularly central obesity, glucose metabolism disorders. And keep in mind that patients with central obesity may not be considered obese on the basis of BMI. And some individuals with a normal BMI may have steatosis, albeit a small percent. About 2.7% of lean individuals can have it. I guess that's a bummer. I mean, I guess they have bad karma. Also, central obesity is associated with insulin resistance. Of course, you're going to have an increased risk of cardiovascular disease, and mortality is a very real concern because of this association. So, about a third of the patients have metabolic syndrome who have this non-alcoholic steatosis, steatohepatitis. And it's a high prevalence in Western society. About 20% of these people can progress to cirrhosis as well as carcinoma. The pathogenesis, and most of the people kind of worked it out, is basically what happens. You got insulin resistance. That is important because you need insulin to keep you from breaking down fat. So if you don't have that inhibitory process, you're getting more fatty acids released. what are fatty acids are going to do? Well, fatty acids are going to also make you more insulin resistant, because insulin resistance is not a discrete receptor process, but it's felt to be an infiltration of the fabric of the cell membrane with these fatty acids released from your fat stores. Also, these adipocytes, these fat cells, release cytokines. Cytokines are proteins that tell the rest of the body to do something bad to itself. It enhances other inflammatory processes. Also, there is more oxidative stress inside the liver cells. And what that does is just bumps off more liver cells, okay? So that's the kind of the pathogenesis. And unfortunately, we're starting to have some specific therapies. And there are some experimental agents that are in study now, looking at ways to impact these fatty acid cascades. Now, of course, we've had information using vitamin E and TZDs, because TZDs shut off some of this fat accumulation in the liver. But anyway, the metabolic syndrome has a high social and economic impact, and it's a worldwide epidemic because the rest of the world is trying to catch up to us, okay? And unfortunately, this is going to be huge, just like it is with the next slide. Chronic kidney disease. 80% of new starts internationally for renal replacement therapy is from diabetes. So we have obesity and CKD. So you don't want to kind of cloud it, because every obese person doesn't have metabolic syndrome, and conversely. But let's just think about it. There's a link between obesity and diabetes. On one hand, there's a link with hypertension on the other hand. And what it probably is that they're inflammatory cytokines that we just talked about. These inflammatory processes that are coming from the visceral fat cells, the portal, the central obesity, is causing a lot of problems. And it's an interesting thing, but I think that this whole reactive oxygen species, all of these cascades, if I may make a big jump right here, are kind of related to, think about this as many buttons, many things. I've got genetics, I've got hypertension, I've got diabetes, I got metabolic syndrome, I got dyslipidemia. On the other hand, I may recreational drug use and these kinds of things. I always tell my patients, please don't abuse drugs, because there's so many bad things lurking, waiting to get you, just existing. So you don't need to help bad things happen to you, because there's something waiting for you anyway. But what's interesting is that when you think about this whole myriad of things that I just alluded to, which is not the important thing, they all channel down via angiotensin 2. If you remember your renin-angiotensin aldosterone system, angiotensin 2 is kind of the button that causes the whole issues with endothelial dysfunction and all these other problems that lead to atherosclerosis. Now, you remember, atherosclerosis, chronic kidney disease, is just atherosclerosis of the kidneys. In other words, microvascular disease. I hope you're following where I'm going with this, is that it's all one big party. Next slide. So when we say metabolic syndrome and CKD, you say, well, I can kind of figure this out, because it's hypertension, insulin resistance, abnormal glycemia, and what I've got now, inflammatory cytokines, et cetera, et cetera, et cetera. So then what we find out is that we have microalbumin. And microalbumin is an important thing, because we find out that it's not just something that we follow because we're following renal disease, but it's a marker of vascular endothelial dysfunction. What that means is that we have a reduction in nitric oxide. Nitric oxide is reduced, and that is the harbinger of endothelial dysfunction. I like to explain it to my patients. Think about, you just have a brand new countertop in your kitchen, beautiful countertop. It's white, just for the sake of visualization. And you decide that you're going to make some Welch's grape juice. So you pull out your can of Welch's grape juice concentrate, and you inadvertently knock the can over. Well, you're going to stain that countertop, right? Well, that would be, let's say, elevated cholesterol, dyslipidemia. Okay, so, your wife whacked you on the head, you put a new countertop there, so everybody's happy. And you decide to, you've made your Welch's grape juice, so you have the right concentration. So there's and the juice is the right setting, but you inadvertently dragged a pot across the countertop or some steel wool or something, and you roughened it. That's what endothelial dysfunction is, okay? And that pot, that steel wool, or whatever it is that would kind of make that surface irregular, that's mediated through angiotensin 2. So what has happened now is that I have less nitric oxide. The lining of that blood vessels is rough. And so now, even with a normal cholesterol level, in other words, if I wasted my made grape juice on that counter, it would stain it, even though it is not elevated. So that's why you have about half the people who have myocardial infarctions don't have elevated cholesterol. So you think about nitric oxide has a lot of physiologic effects, and it's all relating to inhibition of atherosclerosis. It's released and produces vasodilation when you have shear forces, let's say hypertension. Hypertension is just like you're taking a cheese grater and just rubbing along against the lining of your blood vessels. I think that's a nice visual. You can see that it's not good for it. So the vasodilation is nitric oxide mediated, and what it's trying to do is decrease that shear stress. If the shear stress is chronically induced, it leads to upregulation and release of these famous inflammatory cytokines, and these things then cause other problems. Nitric oxide also decreases LDL oxidation. You know, in chronic kidney disease, one of the problems is that LDL not only impacts your coronaries that we always think about, but also oxidation of LDL in the kidney causes scarring, glomerulosclerosis. Nitric oxide decreases platelet aggregation to the endothelium because that's one of the first things you have to do to set up your plaque. It inhibits smooth muscle cell proliferation, and it prevents leukocyte adhesion and infiltration into the vessels. So if I don't have that, the gate is open for atherosclerosis. And again, is it going to be my carotid? Is it going to be my femoral? Is it going to be my kidney arteries? Or is it going to be my coronary arteries? It's the same animal. Why do we get loss of GFR? You're going to get loss of GFR because one, I'm jackhammering your kidneys with the hypertension. But even if you weren't hypertensive, one of the problems is that if I am altering angiotensin 2 levels, what does angiotensin 2 do? It constricts the efferent arteriole. If I clamp down my efferent arteriole relative to my afferent, I'm going to increase glomerular pressures. If I increase glomerular pressures, not only do I get microalbumin, but if I increase it enough, I can kill some nephrons. That's basically what happens. So this metabolic syndrome in chronic kidney disease was first described in the United States. Why? Because we've been eating longer, and then followed by Western Europe. And guess who that person was? That country was Germany, because they try to keep up with us. You know, it may be about 10% less fat than we are, but it's the United States and Germany carry the banner for the metabolic syndrome. But even Japan, China, Thailand, Iran as well. So as we eat a little bit better, or whatever we think is eating better, there we are. Next slide. So visceral obesity and CKD. So we kind of think, you see how I'm building this case here. Aside from hypertension and diabetes, we have other direct pathomechanisms. I'm going to have increased GFR because I got to have hyperfiltration because my angiotensin 2 levels are elevated. I'm going to have increased renal blood flow, and because of this, I'm going to damage my glomeruli. Also, I'm going to hurt my kidneys and actually develop some proteinuria. And you can actually develop focal segmental glomerulosclerosis. We know that if we biopsy obese people, a lot of times you'll see mesangial proliferation, mesangial sclerosis. Not getting all technical, but there are pathological phenomena that occur just because these people are overweight. And so it's not uncommon to have a obese person, or a person with this visceral obesity, because that visceral obesity is what's causing that inflammatory process via angiotensin 2. But anyway, that can cause proteinuria. So it's not uncommon to have a person with visceral obesity without, let's say, carrying a diagnosis of hypertension or carrying a diagnosis of diabetes, could have a half a gram of protein for 24 hours. And if you biopsy them, which we used to do back in the earlier days before we knew about this, you find out that they have much of nothing. A little bit of mesangial proliferation, and guess what? If they lose that visceral obesity, it kind of regresses. So that can be helped. Next slide. Factors to consider in CKD, the sequelae. You see the average BMI, and you can read along those while I talk. But obviously, there's shared risk factors, and you have to think about these factors when we look at our dialysis patients. Because see, dialysis just basically gives you more time to play that hand that you were dealt. So a lot of times patients feel that because they're on dialysis, they don't have to deal with these other things. But as you can see, 47% have a primary diagnosis of diabetes. 56% have comorbidity. Because, even if you're not a diabetic, all of your glucose metabolism becomes altered in end-stage renal disease. So everybody at minimum is glucose intolerant. You have insulin resistance, which is prevalent. Hyperlipidemia, as well as hypertension. Virtually everyone is hypertensive, especially once they're on dialysis, because everybody has a little bit of volume overload. Next slide. Prediabetes or whatever you want to call it, impaired glucose tolerance. I think I guess the politically correct term is impaired glucose tolerance because people don't like the D word. But before people develop type 2 diabetes, they have impaired glucose tolerance or prediabetes. These are the people that have sugars between 100 and 126 fasting. Okay, about 86 million people in the U.S. have prediabetes. Individuals with type 2 diabetes also have significantly increased risk because it's just a matter of degree. So the same inflammatory processes, all of the same pathogenic mechanisms are there. It just has not been as manifested to become, frankly, diabetes. So it should not be in your bag of surprises that they will have more problems with peripheral arterial disease, coronary disease, strokes, hypertension, dyslipidemia, and obesity all together. Because if you have excess, because if you're having pre-diabetes, you're insulin resistant. So you take in some more calories, you're going to store more fat, you will become obesity. So insulin resistance is the common common symptom. And what's interesting with these impaired glucose tolerance people or pre-diabetes, you still should probably check the microalbumin, okay? Because it is an important adverse predictor of glycemic outcomes in pre-diabetes. Pre-diabetic individuals with increased microalbumin, even in the so-called normal range, is associated with increased progression to diabetes and decreased reversal to normal glycemia. So if you got pre-diabetic people and they have microalbumin, you need to be very aggressive. So you have to pull the trigger with them to do some lifestyle changes or maybe do some other things that is beyond the scope of this discussion unless we have time after the webinar is finished. Now, next slide. How to prevent pre-diabetes from turning into diabetes? Well, you see that that's a kind of exercise in futility because they wouldn't have been pre-diabetic in the first place. But there may be some people who may see the light, have an epiphany, and like to do something. But basically, what you got to do is this: you see, there's not one drug here. You got to exercise. You got to lose some weight and eat better. Unfortunately, a lot of times in the urban areas, they're in food deserts. We don't have the option. I'm here on the east side of San Antonio. I used to say naive things like, "But why don't you get out and walk?" And a couple of my patients would look at me like I had two heads, and I realized what their point was. One, there are no sidewalks. Two, it's a dangerous neighborhood. Three, there are dogs wandering around and this sort of thing. So, oh, I see a question here. Elaine Morris. Let me see. Anyway, yeah. The diet, I think there was a question or something about the diet, but basically, You want to have a lower saturated fat diet, higher protein, less carbohydrate. I think that we should think of ourselves not as an insulin sensitivity resistant process, but think about us as basically a glucose intolerant entity, because we can generate all the glucose we need. Basically, we don't need any exogenous glucose sources. We can generate our glucose from proteins. So 30 minutes a day of moderate physical activity, 5 to 10% reduction in body weight, and the diet. Next slide. Next slide. I don't know if I'm stuck. I don't know.
Yes, we're just stuck on this slide for some reason.
That's okay. Then I can elaborate a little bit more. That's fine. But basically, when you think about it, we normally use about 250 grams of glucose a day, okay? And our normal renal threshold is 180 grams. And so we basically generate about 70 grams on our own. So you can see that we really are not dependent upon glucose. And we generate about 70 grams, and most of that comes from the liver. Actually, the kidney generates about 35 grams of glucose, but my organ is so considerate of the rest of the body, it basically generates the glucose it needs for its metabolic machinery. And it also uses glutamate because it kind of doubles, and that's glutamate helps you excrete your titratable acid, because glutamate becomes ammonia, kicks off an ammonia, so you make ammonium, and so it's a very efficient system. But the other amino acids and other precursors go through the liver, and the liver probably generates and contributes about 70 grams. So we filter about 180, we generate about another 70, so we get about 250. Our brain uses 125 grams of glucose a day, even for the less cognitive of our colleagues, but everybody uses about 125 grams. You can kind of acclimate your brain to use ketones, and it can be done, but it's a little difficult because the brain still prefers glucose, so you have to really, really ratchet down your glucose intake. But on the sideline, that is becoming a possible treatment for Alzheimer's, because some people think Alzheimer's is a type 3 diabetes, and that your brain is no longer able to uptake glucose, and so those brain cells die, but they can still uptake ketones and metabolize them. So you probably try the ketogenic diet and see if that might help, or use coconut oil or some of the short chain fatty acids. But going back to guidelines for increasing activity, the people have to be ready, and more, and our gymnasium industry hopes that you're not, because they have, if everybody who has a membership decided to go to the gym, they could not accommodate them. They assume that probably maybe 20% of the people who have memberships actually show up. But you got to think about physical limitations, current activities, barriers to activity, like I was alluding to in this neighborhood, because I think that when we think about healthcare and being healthy, I think one of the things that we don't look at in this country is the fact that there's a socioeconomic portion that is huge. You have to have safe neighborhoods. You've got to have clean air. You have to have all these other things in order for these people for people to have good health, and decrease their stresses and threats of violence, etc. You want to develop a physical activity plan relative to them. Like with my patients, I try to give them a little sheet that basically looks at your target heart rate, and I try to get them to about 70% of the maximum heart rate, and I make some other adjustments if I have them on beta blockers. So I try to give them the idea is that you take 220 minus your age and take 70% of that, or maybe 50% of that if you're on a beta blocker. But the point being is that if you're in the Zumba class, you maybe step every other time or whatever. You may have to go half speed, but you can't, the mother can't run with the daughter, and the dad can't run with the son to get the same aerobic benefit because of the heart rate issues. And you want to start slowly. And I don't believe in this pain, no gain. I think it should be a pleasant experience. It should not be painful. If it's painful, I think it's something to look at that may not be benefit. Okay, I see that. House walking, excellent. So program versus lifestyle activity, except some of these folks live in little hovels of apartments. But multiple short bouts, and I think what you don't want to do is get this boredom, because sit on a treadmill, be on a treadmill for 45 minutes at a time. I think most people will go mad. So do a little short burst. Next slide, please. Metabolic syndrome treatment, as you can see, basically the base of this pyramid is where we go. And lifestyle modification should be a component for all other levels of therapy, because it doesn't matter if you do the other things, because you get a gastric sleeve and you can overcome that if you're not dealing with the right approach. So you should look at it as a pyramid consisting of several levels of therapeutic options, and all patients should be involved in an effort to change their lifestyle. Got to decrease their energy intake, increase their physical activity, decrease stress. That's the biggest thing, because see, if you got a lot of stress, you got a lot of cortisol, and everybody knows that you got to have your comfort food. I mean, I got to have a potato chip or a cookie or something when I'm stressed, and I'm sure everybody else has their little go-to food that when they're stressed. And then if you're not, you don't tend to do that as much, okay? And you got to try to sleep. While there are no randomized clinical trials showing the effectiveness of these behavioral therapies for reducing cardiovascular disease, there are several randomized controlled trials showing that modest weight reduction, even 5%, and increased physical activity may decrease your risk of type 2 diabetes by over 60%. You've probably seen the TV commercials or whatever. I mean, you don't have to get back to your high school weight. You don't have to be, the swimsuit model or, the bodybuilding looking person, but just a little effort. And that's impressive. And a lot of that was actually shown here in San Antonio. Just like a 5% change makes a tremendous difference in the development of diabetes and also in the improvement in your control. So lifestyle modification should be a component. And pharmacotherapy and nutritional supplements can be useful as adjunctive. Bariatric surgery is shown to be very helpful, but it's quite extreme. And hopefully we won't have to go to the apex of that pyramid. Next slide. Treatment for metabolic syndrome, and I'm sure there are many dietitians here, so I'm not going to try to, this is just a kind of general palette here, but there are a lot of puzzles as to the definitive diagnosis in terms of the treatment. Is also, there's no ideal treatment. Gradual weight loss, I think, is the important thing, because contrarily, rapid weight loss greater than 1.6 kilograms per week resulted in worsening of liver disease if you were dealing with the NASH people. There's no strong evidence supporting the use of statins or orlistat. Although initially debated, avoidance of high fructose corn syrup is recommended, and I think that is still an issue, because I think that's where the problem happened years ago. Probably back in the 80s, when the American Heart Association felt that fat was bad, and we said, let us shift to carbohydrate, and our carbohydrate ended up being high fructose corn syrup, and you could see that everybody became portly. Now, caffeine intake should be from coffee and not from high fructose corn syrup beverages. That's really the thing, is the caffeine, and because you're going to increase your triglycerides. Okay. Bariatric surgery has been encouraging with regression of steatosis and steatohepatitis and fibrosis, but rapid weight loss is a concern, because what happens is that if you do this, you may actually worsen your liver disease, okay? So basically a reasonable weight loss. And I think that I'll just throw this out, because this is not there may be some more information when we're looking at visceral fat with GLP-1 receptor agonists, the Trulicities and the Bidurions and the Victoses and these agents are maybe potentially good for the metabolic syndrome, because what we know in the cardiovascular arena, that this is improved vascular compliance. And I know that people who treat patients with diabetes have noted that a lot of their truncal obesity seems to regress when they're on these agents. So this may be something that may help. And obviously it will help with the insulin resistance. Next slide. And like I was saying, there's no approved medications, but there may be a note of hope because, see, the thing is, microalbumin is kind of like a marker that lets us know that we have trouble with our endothelium. And so we can impact a lot of that because you remember I kept saying that the kind of the linchpin is angiotensin 2. So if we impact angiotensin 2, like with RAS inhibition, we may be able to benefit from this. And the idea I put this is if you were into that, you would want to titrate the dose of your ACE inhibitor or your ARB angiotensin receptor blocker against urinary albumin creatinine ratio. You always want to do a protein creatinine ratio because this nullifies any volume issues. And this is a reproducible, and it correlates at least 80 to 90% with a 24-hour urine. Now, proteinuria normally varies about 30% on its own. So you want to cut it in half. And by convention, that means that's our pharmacologic intervention by cutting it in half. So let's say you had a UACR of 500, you want to get it to 250 or less. If it was a UACR of 500, dropped to 400, or it went up to 600, that's kind of the normal background noise. But also, there might be something in the mix with the glucagon-like peptide receptor agonists, the Trulicities and the Ozempic, the Bydureons, and the Victozas. Next slide. Habits to increase health and longevity. I hate to be cynical, but the best thing for that is to choose the right parents, which we aren't able to do. But in all seriousness, you got to be physically active, and that's really what's going to keep you going. Do not use tobacco. You know, one of the tragedies when you think about the toxicity of nicotine exposure and whatever, you can run every day, you can take all your medications or whatever, and you negate all of that with cigarettes. So my patients that smoke, I said, look, if you can't afford one medication, if you just do one thing for me, you stop smoking, you'll do better than all those other things. Eat a health diet and avoid snacking between meals, and try to maintain your recommended body weight. Try to sleep 7 to 8 hours each night. Decrease stress levels. Let it go. Drink alcohol moderately or not at all. Surround yourself with healthy relationships because I think that helps you decrease your stress levels. So the people that get on your nerves, you need to get away from them. And try to avoid environmental risk factors. Next slide. I think this is the summary, and I won't read this to you, but the presence of the metabolic syndrome increases our risk for diabetes, cardiovascular, heart disease, and stroke. And obviously, when we say cardiovascular disease, one subset of that is chronic kidney disease. It's just a microcirculation as compared to medium-sized vessels or large vessels. Most individuals with the metabolic syndrome have insulin resistance and obesity. Therapy should be directed for caloric restriction, increased physical activity, as well as treatment of established cardiovascular risk factors such as dyslipidemia, diabetes, and hypertension. I will end with that, and I'll be happy to answer any questions.
Well, thank you, Dr. Dukes. We have two questions.
Okay.
They're more about the webinar itself.
Oh.
There will be CEUs available for RDs. At the end of the program, there will be a survey to fill out, and the CEU will be provided. And Geeta Patel would like to see more referrals to dietitians to help with the lifestyle changes.
Oh, absolutely. And we just hope that they show.
Absolutely. Because it does take a lot of coaching to change your behavior, so the more help you can get, the better. And let's go to our chat box. Okay, so we do have some chat box questions.
Okay. summarize. Okay, what?
So
Microalbumin.
we have,
Is that what you're talking about? Microalbumin is just albumin. It's protein. We kind of use them all interchangeably. When you look at protein in the urine, about 60% of that is albumin. And it's probably a misnomer now because we use microalbumin because before the regular urine dipstick did not pick up anything less than 300 milligrams of protein. So that's why we called it microalbumin, you know. But it's really the same thing. So it's all the same because if you saw in one of the slides, I said urine albumin creatinine ratio. That could be urine protein creatinine ratio, whatever you want. But microalbumin is really the same as regular albumin. But before, when we were first looking at it, we did not have the technology, and the routine urinalysis dipsticks would not pick it up. And so what the point was that it was smaller than what we were seeing, but it's really not true. It's the same albumin. But the caveat was that if you have a patient in your office, let's say a diabetic, and you did a routine dipstick urinalysis and it was negative, that did not mean that that person didn't have protein. Then you would have to go to the lab and say, let me get a urine microalbumin. But now it's these dipsticks will pick up microalbumin too. So the only thing you still need to send them to the labs to quantitate it, and you want to quantitate that ratio so you can titrate your agent or see what you're doing. So, excuse me. So the microalbumin or the urine albumin creatinine ratio is kind of like the hemoglobin A1C level is for protein, like you would say if you were treating a diabetic. Okay, what do you do? What does it do to the kidney? Well, what it is normally, if let's say, here's a good example. Let's say I am treating your blood pressure, I'm treating your diabetes, and everything is hunky-dory. The blood pressure is good, the diabetes is good, but I have too much protein in my urine. And what that means is that the glomerular pressures are too high, okay? And if they stay high, they eventually cause some other secondary things. So then I go from just a hemodynamic process to a anatomical process. I started affecting the actual structure of the glomerulus. One of the problems we talk about is the mesangium. And if you think about the mesangium, think about those capillary loops of a glomerulus like a rose petals, and the stalk that those rose petals come from, that's the mesangium. So if that mesangium gets screwed up and starts squeezing those rose petals, they kind of wilt, and then it makes an ugly rose. So I like to use this other analogy. So let's say my blood pressure and diabetes is a speed limit. Let's say I'm driving down the street, and if you drive standard, I'm in second gear and I'm going 40 miles an hour. So I'm not speeding, so everything's hunky-dory, but the RPMs are elevated. Or people who don't drive stick, instead of in drive, I'm in drive one, and I'm going 35, 40 miles an hour. So policemen will never pull you over because you're driving the right speed limit, but you're high revving your engine. So the microalbumin protein, the extension of that is kind of like the tachometer for the glomerulus. So if I have my blood pressure control, my diabetes control, and I have minimized my proteinuria, that means that not only am I at the right speed limit, but I'm in the right gear. Because what we do know is that one could have a normally controlled blood pressure at the expense of elevated glomerular pressures, which will be reflected by proteinuria, and have an accelerated loss of kidney function right under your nose. So that's the kind of like, or not to belabor this, but it's the same thing if you were seeing a patient in your office and you had a random blood sugar that's 120. Does that mean that their diabetes is controlled? Absolutely not. So the microalbumin is a tachometer for glomerular pressures or your hemoglobin A1C for things being nice in the renal world.
I think we have time for maybe one or two more questions.
I hope that answered the question about what it does to the kidney. It's just a reflection of elevated pressures.
Absolutely. We do have a question on research for the treatment of the fatty liver disease using vitamin E or TZD.
Yeah, no, it is what I understand is, and that has been some. It's not going to be the therapy now. They actually have some specific inhibitors of some fatty acid pathways now, and I think in your communities you may see they're trying to get some patients to enroll in these studies. But basically, what TZDs did was just stop some of the fat accumulation in the liver, and so once you stop this accumulation process, it was just less of an insult. The vitamin E had a antioxidant effect, but I don't think it was anywhere near the magnitude that these newer agents are looking at. And I apologize, I'm not expert on that, but I know that they're just starting to do some studies now, because I know in several parts of the country they're looking at these complex fatty acid degradation pathways to alter some of these pivotal control enzymes, so that even with this exposure, because it's the fatty acid breakdown that causes this inflammatory process in the liver. So that's what that's about. And so the TZD was try to stop the cascade. The vitamin E was basically kind of cleaning up after the event had already occurred.
Okay, and then there was a few questions about diet composition, basically recommending a paleo style, low carbohydrate diet, or any modifications specific to polycystic kidney disease.
No, polycystic kidney disease, I mean, just think about it basically. There's nothing specific about that. You want a reasonable protein, so you don't want more than maybe 1.2 grams per kilo of protein. And, you know, it's just a matter of paleo diet, I think, is just trying to minimize your carbohydrates and whatever, because there's that fine line. I think it's a little easier to follow than trying to deal with a ketogenic diet. But there's nothing specific. All of the basic things, no matter what, as a general rule, no matter what the etiology of your kidney disease is, be it polycystic kidney disease, glomerulonephritis, hypertensive diabetic nephropathy, the 70% of the renal protection is going to be through blood pressure control, and the rest is either going to be lipids and diabetes control. But we don't restrict protein as much as we did. I know the literature, and we were all taught, 0.8 grams per kilogram and this sort of thing, and the Giordano Giovanetti diet, which we don't do anymore, because we find out, as all the dietitians in the audience know, that you have more morbidity and mortality when you present to renal replacement therapy with visceral protein deficits and low albumins. And so that was really, and I think what we were doing was a negative thing, because what was happening, these people were wasting away, and we were prolonging the time, delaying the time that they needed dialysis, because we were deluded into thinking that we had a stable creatinine, because, we were not doing the MDRD calculation. We were just looking at serum creatinine. So if you lost 20 pounds of lean body mass, your creatinine wouldn't change, and you would be deluded into thinking that everything was okay. Now we have that, do the calculations, and you find out, lo and behold, this person really has a worse GFR than you thought, because you never used to think that someone had your grandmother had a creatinine of 3.5 was really at end stage renal disease, but she is, because she doesn't have any muscle mass anymore. So we also intervene earlier, so we don't have that impotence to restrict protein as much as we did before. Personally, and this is my own bias, I don't restrict at all. The only thing I try to restrict is a little bit of salt, which is also an exercise of futility, but I don't try to restrict any diet, because, you get that affirmative nod, but they don't follow anything you want anyway, because they've been eating a certain way all their life. So I just try to adjust to and make little minor adjustments, let's say to take care of their phosphorus or their potassium or something like that. But for the most part, I try to encourage them to eat a good amount of protein.
Okay, well, thank you, Dr. Jukes. I think we'll end the question and answer session. We're a little bit over 2 o'clock. I'd like to thank you and all of our participants for dialing in today's webinar. Again, the presentation has been recorded, and the recording will be posted on proplete.com. All participants will receive a survey extension after the webinar has been completed, and for those that qualify for CEU credit, they'll be given the certificate after completing the survey. And with that, I'd like to say have a good afternoon and thank you for joining us.
Thank you. Goodbye.
Thank you.